Let's move forward onto our talk today. So we have Associate Professor Stefan Karl with us. Welcome. He leads the Vector-Borne Disease Research Centre at James Cook University, and Entomology Lab at the PNG Institute. His current research program comprises a broad field of studies. So we have basic research clinical trials, including trials of malaria, vector control interventions, zoonotic arboviruses, and vector surveillance, molecular xenomonitoring, which sounds very complicated and good, insecticide resistance monitoring, mass drug administration against lymphatic filariasis. That's a tongue twister. And studies on climate change and vector ecology in PNG. So I welcome you to our second talk in our series. Thank you.
Thank you. Thank you for the nice introduction, and thank you to the center for bringing me down here, and thank you for coming along to the presentation. I think it's been enough said about me already. Bear with me this morning. I got up at 3:30 in Cairns to come down here, and I was actually thinking maybe my talk was going to be tomorrow, but really it was prepared, so we'll find out what's on these slides together a little bit when we go through. I woke up and there was no electricity. I was kind of like stumbling around the house for a little bit trying to find my things, but I made it here. So I supplied with this official center cover slide that says that the title of my talk is Insights from Malaria Vector Control Studies in Papua New Guinea, and I had also prepared an unofficial cover slide before Adrian sent this one to me. I had changed that title a little bit, but what I'm going to talk about is basically an overview of what we're doing in Papua New Guinea. And give you a little bit of an idea about the different kinds of vector control studies, etc., that we're running up there. So for those of you who are not familiar with PNG, it's on the world's second largest islands. It's a fascinating country. It's got a main island, as you can see there on the map, and about 600 small islands. The capital is Port Moresby. It's got about 11 million people, mostly of Melanesian ethnicity. The urbanization rate is low, 14%. An interesting trivia about it is that it's got about 800 distinctly different languages. About 10% of all the spoken languages in the world are only spoken in PNG. Lots of poverty. And it is a regional hotspot for mosquito-borne diseases, including malaria, lymphatic filariasis, and arboviruses, making it a fascinating place for tropical infectious diseases research. In terms of malaria burden, we've got about 1.2 million recorded malaria cases per year in this population of about 11 million people. But there's a lot of underreporting going on, so the real numbers are sort of estimated to be around 1.6 million people by WHO. And the national incidence is about 100 per 1,000 persons per year, but the treatment seeking is only at about 40%. So there's a lot of cases that go unreported. And in addition, about 40% of all people in PNG live above 1,600 meters, where malaria isn't actually really transmitted because it's too cold. And so these 1.5 million cases a year are actually concentrated in the coastal population, which is smaller, like about 6 to 7 million people or so. So kind of here on the map, you can see the elevation map there with these high mountain ranges in the center, and I've kind of just highlighted the areas above 1,600 meters there in the population density map, and you can sort of see that you've got these high population density centers in the highlands of PNG. So yeah, malaria is concentrated in about 7 million coastal people with outbreaks also in the PNG highlands. The clinical cases are are about 75% P. falciparum and 25% Vivax. So falciparum is causing malaria, clinical malaria more often than P. Vivax. But epidemiological, the ratio is about 50-50. So 50% when you go to a village and you do a cross-sectional or something like that, and you see 50% Vivax and 50% falciparum infections. There is a low coverage with effective treatment. I think in particular for P. Vivax, I think it must be close to 0% because you're supposed to take 14 days of primaquine, and almost nobody does that. And so the country is not able to mount an effective control response against P. Vivax at the moment. And the malaria incidence in PNG has been steadily rising since 2015. You can see some of the problems there, the treatment-seeking cascade. So of all malaria symptomatic cases, maybe only 19% receive effective treatment. And the biggest step in that is the treatment seeking, where about only 40% of people seek treatment. Why? Because of the remoteness. About half of all the health centers are closed at any given point in time, etc. So it's difficult for people to seek treatment, and then in particular for P. Vivax, there's also like a compliance issue as well. So you can see the incidence curve over the years up there, malaria sort of steadily rising after the introduction of bed nets. And rapid diagnostic tests and artemisinin combination therapies to kind of counteract, widespread antimalarial drug resistance to these conventional treatment regimens. And that seemed to work pretty well until about 2014-15. And since then, we've seen that sort of steady increase, a little bit of a dip there in reporting due to COVID-19, sort of around 2020, 2021 or something. And we are where we are. Now, a little bit of seasonality, but not very pronounced. Okay, but I'm supposed to be an entomologist or something like that, so I have to talk about the malaria vectors and species and species distribution. So the main vectors in PNG they belong to the Anopheles punctulatus group. That is a group that comprises quite a few different species, and within these species you have species complexes like Anopheles forauti, which is at least 7, but probably the real entomologists can tell me that that is even not enough. There's probably more Anopheles forauti species. Anopheles coliensis, which is supposed to be a complex in itself, or hypothetically. And Anopheles punctulatus sensu stricto. And there's minor vectors called Anopheles langiostris that can also be dominant locally, and Anopheles bancrofti. So there's a geographic and seasonal distribution of these vectors in PNG, depending on the vector ecology. Most Anopheles forauti species are found within a kilometer of the coast. So these are sort of salinity tolerant brackish water breeders that are not often found inland. So they are the malaria vectors that transmit malaria mostly through the dry season when you have these blocked river mouths along the coast, right? And they provide these perfect habitats for Anopheles forauti because they're a bit saltwater tolerant, and they love these kinds of habitats. Anopheles coliensis and Anopheles punctulatus, on the other hand, are found of freshwater breeders, so to speak. So when it rains and all this stagnant water gets flushed out, but all the the hinterland, so to speak, becomes flooded with sort of temporary water bodies. That's where Anopheles coliensis and punctulatus peak. And so you have this alternating pattern between the species in dry versus wet season that sort of maintains malaria throughout the year. So you don't really have that much of a pronounced low season because some mosquitoes that transmit malaria kind of love the dry season more, and some mosquitoes that transmit malaria kind of love the wet season more. And you can sort of see that in the data down there. Anopheles coliensis being sort of more prevalent in the dry season is gray box and whisker, and the wet season is gray box and whisker plots, and then Anopheles forauti being highly prevalent in the dry season. So when you think about seasonality following this kind of wet, dry season pattern, then it's probably not entirely accurate for many of these PNG settings. And then you have this interesting, vector species distribution with Anopheles variety really dominating these immediate coastal settings. And then you go a few kilometers further inland and you get a completely different species distribution. What they're doing, most of them are biting outdoors. So I think that's what they all have in common. They're all predominantly outdoor biting. You can see that they're on the furthest right-hand side graph, so the proportion of outdoor biting mosquitoes for all these different species, about 60 to 80% of them are outdoor biting. When you look at the biting profiles, historically, Anopheles variety has been described as an early biting mosquitoes, whereas the other species are supposed to be later biting. You can kind of see that they are, but it's not like super pronounced. So I would classify all of these mosquitoes as biting kind of like throughout the night, with the potential in particular for Anopheles variety to bite a little bit earlier than the rest of them. It is sort of slightly different, and these are all our data, that we kind of like collected over recent years. And it's a bit in contrast to some of the data that has been previously published, in particular about Anopheles coliensis. When you look at the Walter Reed biosystematics unit website, you can read about Anopheles coliensis, for example, that it is considered to be endophilic and endophagous and highly anthropophilic, and it's believed that insecticide-treated nets and indoor residual spraying programs have been extremely successful in driving that to extinction, etc. That's definitely like not what we're seeing in PNG. Anopheles coliensis is there. It's not indoor biting, it's outdoor biting. It's and so whatever was observed back then, I'm not saying that it was wrong back then. It may have been that way, right? But it's not what we're observing today. When you look at the host, this is a little bit of Brian's data actually here. I just put in there, and it's very preliminary, but and just general across the species. I'm sure there's species differences. You see a lot of human blood meals, a lot of dog blood meals. Traditionally, pig blood meals have been attributed, or pigs have been attributed as being, major blood meal hosts in PNG as well. In this particular study, we don't see that. I don't want to say that that's generalizable, but that is just kind of like the data available to us at this stage. Okay, going on to the malaria control program in PNG. So the program runs on about $20 million a year, so it's considerably under-resourced. So imagine you want to treat something like 1.5 million cases of malaria per year for something like $20 million, and you want to prevent them, then you're not going to get very far. So it's operating within an overall challenged health system with about half of all the health facility closed. One of the lowest doctor-to-patient ratios in the world, very many hard-to-access areas, a very high cost of delivery settings. So if you have to take your bed nets out with these kind of old Russian helicopters because there's no roads, etc., then the cost per net delivered far outweighs the manufacturing cost, for example, of a net manufactured by a factor of 4, 5, 6. So specific challenges include low treatment coverage, very low cure rates for P-Vivax, and a low impact of current vector control tools. Bed nets, insecticide-treated nets, or ITNs, are the only malaria prevention distributed in all malaria endemic areas below 1,600 meters, and systematic bed net distributions have been fully implemented since about 2010. You can see that there are a big old Russian helicopter with all the bed net bales flying out to a place in Middle Ramo in Medellin province, for example, or like, the teams trying to get through these impassable roads, etc., trying to deliver these commodities there. So I think it's important to try and understand what interventions do in order to try and improve things. So kind of try to set out to try and understand what the bed net distributions do in terms of malaria incidence. So taking all the malaria data together from PNG. So there's a system, a routine surveillance system called the National Health Information System that reports sort of like summary data, malaria case data for every month. And you can calculate the incidence rate from that. And then you can overlay that all and you can put it relative to your bed net distributions because you know all the dates for that. And you can kind of try and figure out what the bed net distributions do against malaria. And so this is from hundreds of distributions kind of like taken together, this plot, right, and shows you the relative incidence of malaria after bed net distribution. So what you can see is that so at month 0 is when the distribution happens, and nets are distributed every 3 years. So we want to look at the following 36 months after distribution. So when you take all these bed net distributions together, you can see that they are reducing malaria incidence significantly, but sort of like in the end of the distribution interval, you're back at where you started from. So you're never really gonna reduce malaria apparently with this intervention alone. So since 2014, ITN's distributions haven't really reduced malaria incidence in PNG sustainably. And this trend is similar to other countries in Africa, apparently, and definitely isn't what we want to see globally, I guess, as a sort of malaria research and control community. So, and it brings me to my most favorite topic, which is why that is. And I've been talking about it a lot, and then I apologize if some of you have heard this before, but I think it's an important issue, and so that's why I have been working on this for sort of the last 6 or 7 years. So the only ITN product that was distributed in PNG since the beginning of time is called Permanent 2. And everybody was scratching their heads why malaria was going up in PNG between 2013, 2014. And we, from an entomology side, tried to contribute to that. We were trying to test whether the bed nets are still working, something like that. So we're doing bioefficacy tests using these nets, and we were seeing that they were not actually really killing mosquitoes. And it took another couple of years for us. And you can see this here. And I'm not going to talk about how this graph on the top there came about. It's stitched together by going to many, many different villages, trying to collect bed nets with different manufacturing years that people had stored in their cupboards and stuff like that for later. And what we were able to piece together was that nets of this brand before 2012 used to kill 100% of mosquitoes. That's what you can see on the top graph, these blue dots. It's a mosquito mortality and knockdown. So either 80% mortality or 95% knockdown. That's what they're supposed to achieve according to WHO guidelines. And they were achieving that until about 2012. And then suddenly, and that's the manufacturing year on the x-axis. And then suddenly from one year to the next, they didn't do that anymore. And they were only killing on average something like less than 20%. And so then it took me another couple of years to find out why that is. And only working together with like chemistry people and sort of textile chemists and stuff like that. They analyzed the coating of these nets. And I found that the manufacturer had quietly changed the coating of the net from a PFAS, so forever chemical bad, right? But working really well, and all of our outdoor textiles and shoes and firefighting foams, that's all full of PFAS. So it's not, for a primary healthcare tool that saves lives, it's probably all right to still have it and not phase it out. I don't know, you decide. But they changed that PFAS binder. And you can see that there the fluorine, right? Fluorine, that's what gives it away. The fluorine content dropped between 2012 and 2013. And that coincided perfectly with the time that these nets started to not work anymore. So the manufacturer basically changed the coating formulation of the product from a fluorine-based formulation to an acrylate-based formulation. And that led to the decrease in insecticidal performance. And that didn't only affect the nets delivered to P&G, but that affected the nets delivered to, it's one of the biggest bed net manufacturers in the world. So over 1 billion nets were affected by this. And I can do the same thing and look at, what these nets did to malaria before and after this manufacturing change. And you can sort of see that maybe before the change, these nets were actually able to reduce malaria incidence much better than after. So then, and that's sort of like 2019, right? And so then we thought that, okay, well, maybe just distribute other nets. Get rid of that manufacturer, let's get other nets. They're surely better, and then we'll fix that. Sort of like for P&G. So the program started to distribute other nets, but unfortunately what we're finding is that many of these other nets have similar, different problems that undermine their insecticidal performance. So this is here a durability study that we did for a product called YAHE, for example. So durability studies, you're supposed to follow, a cohort of nets. You distribute them in villages, and then you follow them every 6 months or something, and you collect them, and you do insecticidal efficacy studies, and you check how many are still in the communities, and you count the holes and all these kinds of things. And what we saw with this particular YAHE product, so they're supposed to have 80% mortality for at least 3 years, right? And what we saw with this particular product is even after 6 months, and these are all pyrethroid susceptible colony mosquitoes, the insecticidal efficacy dropped to something around 50% after 6 months. And after 24 months, you have less than 20% left. And after 36 months, and then we published that because I already felt that's bad enough. We don't need to wait for 3 years. Let's just publish now. But then after 3 years, we've got the data now. It's even lower than that. It's close to 0%. When you wash these things, and you can do these wash assays and stuff, you can see that with every consecutive wash, the insecticidal efficacy decreases exponentially. It's not supposed to look like that. It's supposed to stay above 80%. What that allowed us to do, though, at P&G IMR is to really sort of build a capacity for these kinds of vector control evaluation studies. And so we're kind of doing that now for all kinds of different products. You can see the people there, labeling the nets or doing the cone bioassays, massive number. Like, we've gained a lot of experience doing that, counting the holes, or a map, where all the nets were distributed, etc. So we're doing a lot of these studies, but we're not funded to conduct, detailed durability studies for every single product. There's 15 different pyrethroid-only products pre-qualified by WHO. And these durability studies also don't really provide information on the epidemiological impact of nets. You follow the nets and you kind of see, but what does it actually mean? And we are also not really funded to conduct, big cluster randomized trials that you actually would need to do in order to figure out whether one net is better than the other one or something like that. So what we can do is, we can pragmatically sort of try to work together with the program and see if we can, at least, gather some data that can sort of support decision making for the program in terms of like what products they might want to go for, etc. Based on what we can discover there. So what we do together with the program is we try to distribute different net products in different areas of the country. And then we collect the nets again after 3 years of use, because they're really supposed to, it's got to be pragmatic. It's got to not cost a lot of money. So collect them again after 3 years of use. And at the same time, we look at the incidence, sort of like that. But it's not cluster randomized. It's aligned with how the program is distributing the nets. Is supposed to kind of provide some actionable information for the program in terms of decision making around what nets to procure. So you can kind of see our first attempt to do this, sort of maybe like 3 years ago now, because that's why I have the data for after 3 years. So 3 different products distributed in different districts of PNG, kind of like that. Called Royal Sentry, Permanent 2, and SafeNet, you can see. And so the question was, if we can identify differences in performance and what that means. And I say that, these are not cluster randomized, right? This is still not easy to do anyway, because the collections of these ITNs need to be organized, right? This needs to be randomized. You can't just go blindly and ask people to give me, the first net that you want to give me, because they'll give you the most worn out net that they can find in order to get a new one or something. So it has to somehow be organized, and you need to get out there. It's not cheap. And just some impressions from what that sort of like looks like. And so this current study collected ITNs from these 29 districts I've shown before in the map. 6 were Royal Sentry districts, 14 permanent, and 9 SafeNet. And we collected after 3 years of use these numbers of nets, and then we kind of like tested them and also looked at the epidemiological impact in these districts as well at the same time. So what we can see is that after 3 years of use, you can see distinct differences between the nets in terms of their insecticidal performance. So 2 of the 3 products, SafeNet and Permanent 2, had less than 20% insecticidal efficacy after 3 years of use, whereas 1 Royal Sentry had over 80%, almost 90%. And this is a lot of data. So it's without doubt different between these different products. When we look at physical damage of these nets by damage score, and you count the holes and you calculate this sort of normalized damage score, you can sort of appreciate that it's not very different between the different nets. So the major difference between the nets is this insecticidal efficacy. One clearly better than the other 2. So now, in terms of like how we try to analyze the incidence, I felt the need to kind of like explain the graph on the next slide, maybe by explaining this one. So again, like it's 48 months of data, 1 year before, 3 years after the bednet distribution indicated by the red line. That's when the bednet distribution happens. All the spaghettis in the spaghetti plot are like individual districts for the 29 different districts. Malaria incidence data, right? On the y-axis, you have malaria incidence data. And so all these spaghettis for individuals. You can see this very noisy data. When you plot the medians, though, you can see the pattern, right, for the 29 different districts. So those black dots, those are the medians of the spaghettis. And then the black line and the envelope, that is an interrupted time series fit, Bayesian fit to the data, to the raw data. And so I don't know, fits well, I think. I'm not a statistician, but I think it's pretty all right to me. And on the other side, you can see the incidence risk ratio derived from this. So you can sort of see that, yes, on average, bednet distributions, taking all these different products together, reduced malaria incidence in PNG, right? At least in the first year, and then it's sort of creeping back up. And in the end of the 3 years, you're kind of even higher than where you started in the beginning. So that's what these plots mean. And so now we can do that for the 3 different products separately. And so the first one is for the Royal Sentry. That is the net that worked well in the insecticidal efficacy tests, and then permanent 2 and SafeNet. And you can see now the caveats and the shortfalls of this not being a cluster randomized trial, in that we are not able to conclusively show this, right? But we can at least see a tendency, potentially a tendency of what's happening. So for the Royal Sentry districts, I forgot one important sort of thing here in these plots. So for these numbers here, they come from a Bayesian model estimate, right? These are just the probabilities, so 88% probability that in the end of year 1, malaria incidence is less than it was at baseline. That's the probability of that. So you can kind of like see that for Royal Sentry, the probability of malaria being significantly reduced in year 1 is almost 100%. And by the end of year 3, it's still 56%. Whereas for permanent 2, it's only 19% or something like that. So, so you have a probability of less than 1 in 2 for one of these products versus less than 1 in 5 for, more than 1 in 5 for the other one. So while it is not a cluster randomized, and I'm writing a paper, so I try to kind of figure out how I can formulate that, right? Why it is not a cluster randomized controlled trial. I think if I had the choice to protect my family or whatever, right, or I am a program and I'm confronted with this kind of data, it would be relatively clear to me which product I was going to get, because I 95% and p-value, but I kind of care about 1 in 5 versus sort of like 1 in 2 or something. So I think it is evidence, but it's obviously not not enough, and we need to do more. So this has been keeping me busy for the last 7 years or so. All of these ITN products are pre-qualified by WHO. All of them are considered equal. And so that means that the cost is the only difference between them. When a big donor, and it's all donor funded, right? P&G doesn't buy any nets, it's a global fund that buys the nets. And global fund buys the nets that are the cheapest, that are WHO pre-qualified. So if they're all the same in the eyes of WHO, global fund will buy the ones that are the cheapest. Okay, so because they're all considered equal. So we've been providing WHO and Global Fund with data on this issue for almost 7 years now, since 2018. But our complaints have so far not really resulted in the delisting of any of these products. So I'm not saying that I'm after trying to, become famous and get these things delisted, but like somehow we have provided conclusive evidence that some of these things are not working as they're supposed to be working. And the response hasn't been what we had expected, if that makes sense. So there's been several global newspaper articles about this. The P&G health minister wrote to Dr. Tedros from WHO about this. The company repeatedly threatened to sue us, and you can see all the papers, and there's been a book written. It's free. You can download it. It's called Netting Paradise there. And we continue this work. I'm not trying to say that this is the only thing, that compromises ITN efficacy and P&G, not at all. There's clearly other things, sort of like observed decrease in usage in some areas for sure, but you can see that it's quite stable, at least from the beginning of the mass distributions until recently. And there's also some reason to believe, to question some of these are malaria indicator surveys, and we have some questions about the quality in there of the surveys, and they are not really the same. When we go to these villages, we kind of come up with different numbers. When you ask people why you're not using ITNs, most people say it's too hot, they get skin irritations from the insecticides, it's too much work to put them up, or there's bed bugs. We were interested in the bed bugs, for example, here. So we did a study, found that about 50% of rural houses in Madang and Sepik provinces have bedbug infestations. for example. We sent them off for molecular sequencing. They're all resistant, all have the same 3 mutations in the voltage-gated sodium channel. They are for pyrethroid resistance, all the same, and the bed nets don't kill them. So that means that, the people feel trapped with the bed bugs in the bed nets and they don't kill them. And so it kind of reduces usage. And the study team all being done by John Kevin and the study team. We do a lot of work trying to kind of quantify protection gaps. So you can imagine that if mosquitoes bite early and outdoors, then, bed nets will never prevent all the transmission. There's always going to be a gap there. And so we try and quantify that by mapping people's behavior in different villages, between males and females maybe. So you can see there's different behaviors, what people do over the course of a day or something. And then the red bars are the mosquito biting times, and you can kind of like see where it's not overlapping with sleeping. So how can these people be protected by bed nets when the mosquitoes are already biting, when the people are still at home chatting, resting, or whatever. So that's, we're not wedded to this bioefficacy idea completely, but it is certainly something I think that plays a big role in this. But there is these protection gaps here. You can sort of quantify it, right? What proportion of the bites what proportion of the bites are received when people could theoretically be protected by bed nets, when they're sleeping or something, versus, what bites could never be, what proportion of bites could never be avoided using bed nets. It's sort of like X, right? When they're still out there. And you can plot that. That's that minimum protection gap. So, say that, and it's different for males and females because males tend to hang out outside a little bit longer than females, etc. And over the age groups, it's also a little bit different. So you can see how that differs for children. It's less because they get to sleep earlier and all that. But you could say that maybe on average, 30% of all that human vector contact could never really be avoided using bed nets anyway. But if the mosquitoes die immediately when they come into contact with a bed net, then it would obviously be much better because then all of that doesn't really matter. We can match blood meals from mosquitoes and humans here. Another nice work from John Kevin showing that, males are disproportionately exposed to mosquito bites versus females. And what else does it show? Age groups also, young adolescent people wanting to have their own bed net. That goes back to the distribution scheme. One bed net for each 2 people. When you're like 14 to 20, you don't want to share your bed net with somebody else like that. So these people just don't have access. It's not that they don't want to use nets. It's because they don't have access. Yep. Then we keep ourselves busy with a lot of capacity building. It's clear that we need additional vector control tools. Bed nets alone are not doing the job, in particular not those that we're distributing at the moment. So we're doing a lot of studies with residual spraying, larval surveillance and control, and spatial emanators are the latest thing now. And the nets, obviously, and we built this infrastructure, experimental huts to test vector control tools, large flight cages up in Madang, mostly due to the hard work of Petrina, who's a postdoc working up there from my group and permanently, and then the insectary capacity. So I just have 2 or 3 slides about the spatial emanators because, as they're the latest pre-qualified or recommended vector control tool for malaria by WHO here just from August 2025. And so we've done a small entomological study looking at how they work. So these are just these little matrices there. You can hang them up. They emanate a volatile pyrethroid called metafluocerin or transfluocerin, and that kind of supposed to create that sort of safe space and reduce biting human vector contact. So we had 3 study arms, 12 houses in each arms. We either hung them up only indoors or indoors and outdoors, or not at all in these controls. And when you think about PNG settings, what does indoor and outdoor look like? So I can put some examples here of indoor spaces versus outdoor spaces. So outdoor spaces mostly like under the houses or verandas where people hang out or something like that, and then indoors. And then we collected mosquitoes for 9 weeks using human landing catches in all these arms, and we try and quantify. So the arms control is black, and then indoor only blue, indoor plus outdoor red, and then we can do all these statistics. Looking at the cumulative number of bites per house, you can sort of see that, yeah, okay, both, in particularly indoors, biting is much suppressed in both of these arms where you put these emanators there, whereas outdoors not so much. And then we can calculate the protective efficacy, which is just 1 minus the incidence rate ratio, and you can kind of see that for both of these indoor scenarios, yeah, you get significant protection indoors, maybe between 80 and 50% or something like that over the duration of that 9 weeks, but maybe not so much outdoors. And in fact, outdoors you tend to observe an increase in the intervention arms, which kind of potentially hints towards mosquitoes being diverted from indoor to outdoor biting. And so you can kind of like interpret around that a little bit, but obviously not conclusive here, because not statistically significant. And then you can try to calculate the cumulative bites averted as well. And you can see that, okay, indoors definitely bites are averted. So yeah, okay, 70 to 80% reduction in the indoor biting rates, no real reductions outdoors, some evidence for diversion of mosquitoes outdoors, and we need longer lasting products. So that was a short lasting product with an advert or recommended duration of efficacy of about 1 month. So now we're working on with a long lasting, and I can't show that yet because that is actually sort of not allowed. But a longer lasting product with an advertised duration of efficacy for about 1 year, right? And then you can see how that potentially starts to make sense from a delivery perspective as well. And so we're trying to prepare for a larger, even cluster randomized trial starting next year with those longer lasting products in PNG. Some more slides, random stuff, and you can stop me if you like. So we do some sort of work on lymphatic filariasis as well, doing cyno monitoring, so collecting mosquitoes before and after mass drug administration to kind of see what it's doing and how many mosquitoes are still infected after you do a mass drug administration with against lymphatic filariasis, etc. So we're partnering with the program to do that. We do a lot of insecticide resistance monitoring, and I know that there's interest in arboviruses here. So lots of Aedes insecticide resistance monitoring as well. And interestingly, we see that in PNG you don't have any pyrethroid resistance in the anopheline populations, but you do have it and widespread in the Aedes populations, in particular Aedes aegypti. This is a map of the insecticide resistance in PNG. On the y-axis here, you have all the different insecticide classes. That's all data that our lab has generated. And on the x-axis, you have the different species: Anopheles varieties, Anopheles albopictus and Aedes albopictus and Aedes aegypti. And so these green, red, or yellow squares denote whether these populations in these provinces were resistant or susceptible. Green means susceptible. Do stuff on One Health, collect lots of mosquitoes around piggeries and commercial piggeries to see whether there's JEV transmission, things like that. So there's Joylyn and Naomi. We do a lot of work together with the ACDP in Melbourne, David Williams, and just see some of these trap collections there, and poor people have to sort through them and then subject the actual mosquitoes to PCR to see if there's any virus in them, etc. So we do this sort of stuff. And we do some climate modeling, and I just leave you with that, just maybe for the future. So that's something that I published earlier this year. What do you actually expect malaria to, how do you expect malaria to develop in PNG going forward? So we think that until 2040, and that's using a conservative scenario, temperature will probably increase by 1.3 degrees across PNG. It's probably gonna happen now. And so how will that change the transmission environment? As I told you in the beginning, right? Somehow the highlands are mostly malaria free because it's too cold, but if the temperature increases, the altitude where mosquitoes can propagate and malaria can be transmitted will also increase. And so I don't want to dwell on this because I know my time's up, but you see I'm enjoying this. What you gotta take population growth into account in this. So maybe in 2019, you had about 11 million people living in PNG. If you assume some kind of population growth estimate that's published by 2040, that will be about 18 million people. And if you just assume that malaria will stay where it is, and you don't assume any kind of expansion of transmission range due to climate change, creeping up into the highlands or something like that, then the number of people living in malaria endemic areas of PNG will increase from something like 6.5 to 10 million people. Right? But if you include that temperature increase, then that estimate changes to about 14 million people. So what we can say is that the total population living at risk of malaria transmission in PNG is expected to roughly double by 2040. And 50% of that increase will be due to rising temperatures. And so maintaining the current levels of malaria control in PNG will require substantially more resources, and we don't see that coming soon. And I think that's hopefully it. Yeah, that's it. So that's just the team in PNG, the entomology lab, and just some other impressions. And it's all due to their hard work that I can stand here and present all these nice things. Thank you. Super.
All right, nothing online yet for questions. We got any questions in the room? Yes, at the back. Hi.
One just idea. What about the data control to analyze that of RCD? Because you can synthesize sort of artificial controls. And yeah, let's talk about that, but it's an option.
Yeah, I don't quite understand, but we can definitely chat about it.
But the other question is, obviously the key gap is that 30% outdoor biting that remains an issue. And so how do you envision really addressing that, especially with the emanators that are potentially going to be sort of pushing mosquitoes even more out?
Yeah, so I'm not allowed to show the data, but with the other product that we've been testing, we see substantial reductions. We did the same trial, sort of like substantial reductions also in outdoor biting. So it's a different chemical that's in there, and so we do see that it's more short-lived than it is for indoors, right? But yeah, I don't think it's a silver bullet like at all, right? But at least it's something. So we'll see.
Yeah, really good. I just had a question about the last couple of slides. Did you look at that separately for violence?
Not yet. No, this was actually only for falciparum. So it's really simple. Like I just took the temperature susceptibility curve for the combined mosquito parasite Plasmodium falciparum system that's already been published for African settings, and it's just applied that to the PNG geography. So you can definitely do a much better job. And we know that Vivax is more easily transmitted in temperate climates, and as such, it can be expected that Vivax, would probably be even more prone to expand into these highlands regions. It's something that if I get a PhD student, then I'm.
The altitude, do you know this, whether has this been looked at or impact by us?
Yeah, you can certainly see falciparum transmission ending, trailing off at lower altitudes than Vivax transmission, like already. So I think it's going to be relatively easy to. The data are scarce, right? As soon as you kind of go into these highlands provinces, the incidence data, there's just not so many cases. So coming up with like statistically robust estimates of that, just difficult. But yes. And the routine system doesn't tell you whether it's Vivax or falciparum. You can infer.
Yeah, well, thanks for the great talks. Have you analysed what it is that's different about the Royal Century?
Not so far, but so they're different, right? So the SafeNet and Permanet, they're coated products, and Royal Century is like an incorporated product. So that's the ones where so coating, right? You have a polyester fiber, and you put a coating onto there. You dip it or something, and it goes over rollers. Whereas incorporated product is like extruded plastic polyethylene, right? So you have a big bucket of plastic. You put your insecticide into that. You stir it around, and then you extrude these fibers, and then you make your net. So the insecticide is like in there. And so I think it's basically maybe that difference. But they are totally different.
What do you think the social political acceptance, or maybe the overall outlook for having GM mosquitoes to test?
I don't know, because I don't think we've ever done any sort of like acceptability study around that. We do, I think it's kind of like something that we are planning to do in the future. So we do acceptability studies for other vector control tools, like asking people, right, what they feel about using this and using that and stuff. But yeah, genetically modified mosquitoes haven't, we haven't included them yet. So I really couldn't tell you. I think that there might be some skepticism among the people, right? And some, considerable work that would need to be done to socialize that. But that's just a hunch.
Yeah, off the back.
No, that would be easy, right? That's what we're asking them to do. But they're saying that, they phased that out because of environmental concerns and stuff, but that's just an excuse. Yeah, it's been reported from some other countries. The main problem, I think, with that is that this effect is masked in Africa, where you have pyrethroid resistance everywhere. Because the mosquitoes, they don't die anyway on these products, right? Because they're single pyrethroid only products.
Have you looked to the PFAS? Obviously, is the problem.
Yeah.
So there's just been a big study in the ACT around PFAS contamination from the fire extinguisher use.
Yes.
I wonder if it's worth looking into that literature to see what the levels of PFAS are toxic. Maybe that's something.
Yeah. So my view on this is that, yes, generally, I would say that it's a very good idea to phase out, these forever chemicals. But do we need to start with, a healthcare product that is a first-line healthcare product that's actually protecting people from dying sort of like year on year, before we have a mature alternative solution, when we are still using these chemicals in all kinds of day-to-day, articles that we are using here every day? That's the question. And I don't accept that sort of argument, because I feel the answer to this question should be clear.
what kind of testing does the WHO to release these products?
So, yeah, no, so that has also changed. There used to be something called the WHO Pesticides Evaluation Scheme, and that has recently been superseded by WHO prequalification vector control tools. So what manufacturers, and I think some of that has to do, at least I tend to hope that some of that has to do with the things that we have done. Manufacturers have to supply detailed dossiers to WHO, and then they are kind of like evaluated, right? And there's different components, different studies, lab, semi-field, field, whatever, right? I think it's not that. I think the need is well recognized and everything, but how do you police it? Like, you know, how do you really make sure that manufacturers don't, like we see nets arriving in PNG, you can open one container, a single batch, you get products of different denier, you get products of different color sometimes, you know, so they're putting whatever in there and you can't police it. I think the good intentions are there.
I could imagine someone sort of developing, say, a somewhat more friendly chemical that you could put in your wash powder or something, you know, so when they wash the nets, you get it sort of reactivated or something.
So it's not an unsolvable problem.
All right, any last questions from the floor? I'd like to thank Stefan for his great talk today, and we'll give him one last round of applause. And